Okay, so let's go on with pediatric assessment of the child. Oh, sorry. When you are doing pediatric assessment or any assessment, you want to definitely collect information. So data collection about a child occurs in a variety of health settings, and it's important to gather information regarding the child's history and current health status. Also, data is collected through a variety of means with children. So it can be done through the interview, physical exam, and results of diagnostic tests and studies. Now, the interview may, depending on the child's age, may or may not be done with the child themselves. The physical exam, obviously, and then any diagnostic tests or studies. All right, conducting the interview. Subjective data. So subjective data involves the child and the caregiver, establishes the relationship between the nurse, child, and family. The setting should be quiet and private. Introduce yourself to the child and the caregiver. Be sure that you know, no matter the child's age, be sure that you are also talking to the child. Include the child in the conversation. And state the purpose of the interview. All right, the reason is you're trying to get more information about the illness or the reason for visit. My dad always hates it when we go to the doctor and they say, "What brings you here?" He's like, "Why haven't you read? Why don't you know what I'm here for?" And I have to keep explaining to him that that's not the point. The point is they want to hear in his words why he's at the doctor. All right, so also included in your subjective information, you want to maintain a calm and reassuring manner to establish an environment of trust and comfort for the child. Past experiences with healthcare system may influence how the child and or the caregiver react to the interview process. So this is a good example of why you need to make any aspect of your nursing care as pleasant as possible, because they will carry these experiences on to their next medical experience. All right, the child may sit in the caregiver's lap if needed, and oftentimes that is how most interviews and even physical examinations are done for pediatrics. Age-appropriate toys and activities may be provided to occupy the child. The child can play with equipment. It might ease the concerns. If they're scared, is the stethoscope going to hurt? You can easily give them the stethoscope so that they can play around with it, manipulate it, and see that it's not going to cause any pain. If there's a language barrier, be alert. You need to provide a translator. Always have to have a language line if there is no translator available. You cannot use family as an interpreter. Remember, other cultural variations are also appropriate, such as in some cultures, the male does all the speaking. So for my patients, I want my moms to talk to me when I ask them questions, especially the younger moms. But I have to realize that in some cultures, it is going to be the males that are going to answer consistently. All right, so you can see physical exam being done on the mom's lap. Now, interviewing the caregiver provides most of the information needed in caring for the child, especially if the child is an infant or toddler, obviously. Be sure and observe interactions between the caregiver and child as they answer questions and interact with each other. You can pick up a lot of cues. The nurse must remember to be non-judgmental in the responses, and we've talked about this before, but being very open to whatever they say to you and not shock and awe on your face when you hear what they say, just very open and non-judgmental. All right, give caregivers a chance to express any concerns and anxieties. Be sure that you use the child's name rather than your son or he or her. It just makes it a more personal experience. Now, when you interview the child, you want to include the preschooler and the school-age child in the interview. Use age-appropriate questions when talking with the child. Use age-appropriate language. That's a really big one too. Okay. Have interest in the child and what he or she is saying. So if you get onto the child's level, eye-to-eye contact shows that you're not doing 500 things at once, but you're actually interested in what the child's saying to you. Using a doll or stuffed animal that the child brings or is familiar with can help ease some fears during the interview process. So you can see an example here with this child with his little teddy bear. Now, be honest when answering the child's questions, and this establishes trust with the child. So things like, is this going to hurt? If they're going to get an IV, yes, it's going to hurt a little bit. So don't say, no, it's not going to hurt when you know it is, but rather explain the situation. It may feel like a tiny little pinch for just a second, and then the pain's going to go away. Use stories or books written at the child's age level to help with understanding. And there are tons of books out there now. Make the child feel that his or her comments are important. So do not appear rushed. Don't be doing other things. Don't be charting, documenting, moving on to the next question before the child's completely answered the first question. Right, interviewing the adolescent. Adolescents will provide information about themselves. So you interview them in a private to encourage them to share information they may not share with the caregiver present. Especially true if asking questions of a sensitive nature, such as drug use or sexual practices. They will often talk, but they will usually talk just to the physician and not with their parents in the room. So oftentimes, like even now when I go in for a physical assessment or checkup with my kids, we go in, we do the checkup, they'll ask, do I have any questions? And if I want to, I can step outside of the room and talk to the physician as well. And they always will say, okay, Mom, I'll have you step out in the hall. And I have to go to the hall while the physician asks my children specific questions. And a lot of it's questions about sex and drugs and things like that. They'll often elicit a lot more responses. Right, obtaining client history. So the plan of care will be developed by the child's health history as well as the child's current condition. So while collecting the health history, note what the child and family knows and understands about the child's health. So they may not seem to comprehend the severity of the child's illness, or they may be overreacting to a very minor illness. I had multiple phone calls when I triaged telephone calls for pediatrics of parents who were just panic stricken over things that were really not that serious, and you just kind of had to reassure them and explain the situation to them. And then I had some parents that called that I thought, oh, you really should be kind of panicked. And they clearly were not. So just making sure, evaluating what they know or don't know and how they understand the illness is really important. All right, biographical data. Identifying information about the child, the name, address, phone number, caregiver information. Biographical data is confidential and part of the legal record. All right, other information, nicknames, foods, likes, dislikes, food or any other allergies, what their sleeping schedule is. We tend to assume everybody goes to bed at a certain time, but you really, for children especially, you want to try to keep them on the same schedule in the hospital as they are on at home, if at all possible, as well as toilet training status. So are they potty training? Are in the process of potty training? You really need to try to follow through on that as well while they're in the hospital so that it's not a setback. So while we assume all children sleep at night, I'm floored sometimes when I would get off work at midnight and stop in Walmart to get a loaf of bread or whatever on my way home from work and see all these little children. And I just never could understand it. But then I had to start really thinking. My brother-in-law and sister-in-law used to both work night shift. So they had a daycare that kept their kids for nights so that they slept during the day when their parents slept, and they were up at night while their parents were up. So, you can't jump to conclusions. You need to figure out what that schedule is. If they are potty training, the special words that indicate if they're having a bowel movement or if they need to urinate. Right? You're collecting information on their chief complaint. Is it a well child checkup? Immunizations? Are they ill? Get the most complete explanation. Repeat what the caregiver statement has been regarding the child's complaint. So this is to clarify. You brought Sally in today because she was complaining of left ear pain. Okay? Sometimes they go on and on and on to tell you a big long story and you really aren't sure what the true issue is. So that really helps to bring it down to one point. Your present illness history. What are the symptoms the child is currently experiencing? When did they start? How long have they been present? Describe the symptoms, including frequency and intensity, and how the symptoms been treated thus far. Does anything make the symptoms better or worse? If your child has cold symptoms, are you giving him or her cold medication? What medication are you giving? How often are you giving it? Do you notice any difference? That kind of thing. You're also collecting a health history, so ask the caregiver about any family health history. Oftentimes, if you're going for specifics on, for example, when we go to specialty physicians, so asthma pulmonologists or ear, nose, and throat doctors, all these different specialists, they want to know your prenatal and pregnancy history. And goodness knows that was a long time ago for me. So it's very hard to kind of drum up some of these things, but they really help. This family history is really used for preventative teaching and to address any risk factors. So could something from early on be causing the symptoms now? Childhood illnesses, chronic family illnesses, hospitalizations or injuries, and it's also a good time to do age-appropriate and developmental safety teaching. All right, we're going to do a subjective review of systems using the head-to-toe approach. Information is gathered from the child and or the caregiver. The body system involved in the chief complaint is reviewed in specific detail. So we're doing a complete head-to-toe approach, but if I come in for sinuses, I'm really focusing on sinuses, but I'm doing everything as well. Right? Allergies, medications, and substance abuse. Discuss allergic reactions for foods, medications, environmental allergens. Find out if the child is currently taking any medications, prescribed or over the counter. In the adolescents, assess for drug, alcohol, or tobacco use. And again, they may not tell you if the parents are in the room. And I think I've told you guys before, it's amazing what people will tell you if you're very straightforward, non-judgmental, very factual, and asking questions. They will tell you a lot of information. All right, lifestyle. Oops. So school history. What grade are they in? Every time we go to the doctor, what grade are you in? How are you doing in school? How's your behavior? Are you getting into trouble in school? What's the social history? So what is your home setting? Who all lives in the home? Where do the parents work? Do they have siblings, pets, religious, economic? Who cares for the child? Are there divorce or separations? And it's really important for everyone to know about these things so that everyone's kind of watching out for the child in the child's best interest. We're doing a personal history, so hygiene, sleeping patterns, elimination, activities, exercise, special interests, how to handle emotional situations. You know, do the children act out, or does this child withdraw and kind of introvert themselves? Are they thumbsuckers, nail biters, temper tantrums? What's the behavior? All right, you're doing a nutritional history, so their eating habits, food preferences. It does me no good as the nurse to serve my patient spaghetti or mac and cheese, things that most all children love, if you were serving that to my children who do not like pasta. So I need to know this, okay? Nutritional concerns, are they on any kind of special dietary restrictions or dietary modifications? Developmental level, ask questions related to the child's level of growth and developmental milestones. This is why you have to know this, because you need to know if this is developmentally and age appropriate. So knowing appropriate milestones allows you to determine if they are in fact appropriate or if there are concerns that need to be addressed. You know, when does the child first say their first word? When do they walk, crawl, sit up by themselves? All right, then in objective assessment, we're getting baseline vital signs, height and weight, and we're doing head to toe, the examination of the body systems. But for the objective assessment, it's not usually done in the head to toe approach like it is in an adult, but rather in an order appropriate to the child's age and developmental stage. So aspects of the exam that seem traumatic or uncomfortable are going to be saved for last. Okay? So remember your subjective data, your subjective assessment is where you're asking questions, doing the review of systems, the head-to-toe assessment, so to speak. The objective assessment is the hands-on. So this is when we're laying our hands on our patient and going through our actual assessment. And this is when you're not necessarily going to do head-to-toe, but you're going to do least traumatic to most traumatic. All right, so the caregiver may assist in some procedures, such as obtaining a urine sample or taking a temperature. Children will scream bloody murder over a temperature. The nurse assists the practitioner in conducting the physical exam with special focus on the symptoms the caregiver or child has described. All right, the child can sit on the parent's lap, remember. The nurse's primary role is to support the child. So the nurse documents all findings, especially those findings that are not within normal limits. That's what WNL means. You don't ever say anything looks normal. It's charted either within normal limits or within defined limits, WDL. And those limits are usually listed for you so that everyone knows what you mean when you say within normal limits. You're saying it's meeting these certain criteria. Make sure to describe in detail any unusual findings, and all information gathered is used in planning the child's care. All right, general status. Use normal growth and development stages to determine if the child appears to fit the characteristics of the stated age. You're observing for the general overall appearance, facial expressions, speech, their behavior. Is everything appear to be age appropriate for this child? Face and body should be symmetrical. Proper body weight and height, which you'll chart it on a graph, given their height and weight, and see if it matches up, if they're in the 50th percentile, 90th percentile, 10th percentile. Proper nutrition, that there are no signs and symptoms of malnutrition. You're assessing for poor hygiene, that they're mentally alert, and that they have symmetric body movements, which in most every child will be fine, but you have to know this for that one child that's not going to meet all these criteria. Okay, you're observing the skin, their skin turgor. Now, how are you assessing skin turgor for the infant and toddler? It's discussed in the video that we watched, but for an adult, you're assessing skin turgor on the back of the hand, usually. But for an infant or toddler, you're assessing skin turgor on their abdomen, okay? You want the color to be pink, okay? But what you have to assess is, are they pink? Are they pale? Are they gray? Are they mottled? If you're unsure of mottled, look it up. You need to know these words. Note for cyanosis by looking at the oral mucosa and the mucous membranes. Okay. What are normal newborn findings? So one of the big reasons why you're looking at the oral mucosa and the mucous membranes for cyanosis is because normally for newborns, they have acrocyanosis. So their hands and feet are blue all the time anyway. So normal newborn findings are going to be acrocyanosis, where the hands and feet are blue initially, as well as milia, which are almost like little bitty pimples across the face and nose, any birthmarks, Mongolian spots we're going to talk about. So you need to be sure that you know what's normal and document it. So you're looking for any lesions. They may have some lesions from maybe a cesarean section, and the scalpel accidentally nicked one of their buttocks or a shoulder. Any bruises. You know, where are bruises normal findings for any children? Okay. Bruising is not ever normal on the buttocks or anywhere on the body per se, but it's normal for children to have a lot of bruises on bony prominences. So on their knees, elbows, legs, shins, you know, where they're going to fall down a lot. The presence of scars or birthmarks, and you can see these pages in your book for some really good pictures. And it's essential to document, especially during your initial newborn assessment. All right, things like Mongolian spots, all I can think of is stork bites, but things like that. You need to be sure that you're documenting those. So here's your Mongolian spots, or your dark gray discoloration on dark-skinned infants, port wine stains, nevi, milia, erythema toxicum, which is newborn rash, mottling, Epstein pearls, and acrocyanosis. You need to be sure that you understand all of these normal skin variations. So make sure you know what these are. If you don't understand my definitions, be sure you look them up so that you have a good feeling for this. So here's some different pictures for you. Mongolian spots. Okay, here's port wine stains. There's hemangioma. Right here are little stork bites. They're usually here and on the nape of the neck, so on the back of the neck. This one kind of got in here unexpectedly. Hair, so you're doing a hair assessment. We're looking for the texture, the thickness, distribution. Is it clean? We're looking for any head lice as well, nits. All right, psychological and behavioral status. So you're observing for factors that influence a child's behavior and how often that behavior is repeated. physical, emotional, intellectual. Be sure that you include the child or consider the child's developmental stage and abnormal environmental factors of the healthcare setting and separation from a caregiver when you're evaluating this stuff. And note if the behavior is inconsistent, unpredictable, or if any apparent reason for the change of the behavior. Okay? There are a lot of very good information here in your book: developmental stages, LEAFR, newborn, toddler, preschool, school age, and adolescent. Measuring the height and weight. So these are indicators of growth and development. That's why we measure this. If they're consistently in the 10th percentile, but they're growing, fine. If they're in the 50th percentile and then they drop to the 10th, we may have some problems. Should be recorded each time the child is taken for a routine checkup, but weight is done each visit for medication calculations. In the hospital, it's taken upon admission and daily, and it's charted and compared with the norms of other children of that child's age. All right, collecting information, plotting the child's growth is a good indicator of health status and gives us a picture of how the child is progressing and often indicates wellness. So that's why you'll see where they come in and they will chart the height and weight and whether they're in the 50th percentile, 95th percentile, 75th percentile, or where they're falling on this chart. And it just shows a nice progression of how the child is growing. Right? Obviously, like I just said, they're indicators. Make sure to keep in mind the size of other family members. If the mom and dad are both 5 foot tall, you can't expect that this child is going to be 5'7". You have to take into account all of these things, okay? Normal findings on growth charts range between 5 to 95%. Major peaks and valleys over time may indicate problems such as failure to thrive, obesity, weight loss, or growth retardation. So you need to monitor those things. All right. In the healthcare setting, you're going to weigh the child the same time each day on the same scales, wearing about the same clothes for the older child. All right. Infant is weighed with no shirt, no diaper, just naked. Place the paper or pad on the scale. So you place the paper or pad on the scale first. Then you zero out the scale so it takes into account the weight of that paper or the pad. Then you place the naked infant on the scale and weigh the infant. Right? You keep a close hand at the infant at all times, but not touching, because if you touch the child, that will alter that number. The child who can stand alone can be weighed on platform scales without shoes, and bed scales used for children who can't get out of bed. Okay? All right, heights. Infants and small children who can't stand alone are going to be measured lying down, so you'll lay them flat. Some places will have a bed like against a wall where they'll have a piece of wood that they move up and down the bed, and it has a measurement on it, kind of keeps a ruler on it. Others will have just a table with paper on it. They'll mark the paper at the head and at the child or infant's foot, and then they'll take the tape measure and measure that length. If the child can stand alone, obviously they're going to be measured standing against the wall. The hardest part is making sure their feet are flat on the ground, their heels are touching the wall, and they're standing up nice and straight and tall. Head circumference. Head circumference is measured routinely in children until they're 2 to 3 years of age, because we're making sure that the head is growing with the body, not too large, not too small. They're plotted on the growth chart as well to monitor the growth. All right. So here's different pediatric heights. This is standing. So this child is standing, getting the height. This is your head circumference. This is your length, abdominal circumference, chest circumference. This is what you'd measure on infants. Then you've got your child standing on the scale here, and here's your baby being weighed. Now this baby is being weighed here with its onesie and diaper on, obviously. But for the most part, especially because you're usually trying to get a pretty accurate weight, they will, like I said, put a piece of paper or a pad down here on the scale, zero out the scale, and then put the baby naked on the scale. That's the best way to get an accurate measurement. All right, so newborn pediatric admission. We're going to orient the child and caregiver to the unit, room, and regulations. Always be honest with the child about why they're being admitted and any procedures that take place. Again, don't lie to them. Don't tell them it's not going to hurt if it is. Allow the caregiver to stay with the child if at all possible. Most rooms are private rooms in children's hospitals, and they will have a bed for the parent, and they actually prefer that the parents stay and help care for the child. You need to be flexible with the rules, so you need to have allow family to be able to come and go. Admission assessment of a normal newborn is done within the first few hours after birth. The RN is responsible, but the LPN may be asked to assist. You conduct an exam in a warmed area with plenty of light. You cannot do a very good assessment if the light is really dim. You can't tell if they're have circumoral cyanosis, so if they're blue around the mouth or lips. You can't tell how much acrocyanosis they have, which is blue hands and feet, if you are in a really dimly lit area. Exam should be done as quickly as possible because you want them to not lose, you want to keep them as warm as possible, so you're usually trying to keep them wrapped up in blankets, a hat on them, and things like that to keep them warm. All right, order of assessment for a newborn or child. The exam is general observations to specific measurements. So your head to toe approach, but again, head to toe, but least invasive to most invasive. Okay, so overall you're just generally getting a look for your overall physical appearance, measuring vital signs, weight, length, ending with the neural reflexes and gestational age assessments. All right, there's some information. I need to check and make sure that these page numbers are actually correct page numbers for you, so I'll look and try to update that if that's incorrect. General body proportions, you've got your vital signs, respiratory rate, heart rate, temperature, physical measurements such as weight, length, head circumference, abdominal circumference. Your head to toe assessment includes all of the following. Neurological assessment, behavioral assessment, gestational age assessment. All right, so vital signs, respiratory rate tells how well the newborn's adapting to the extrauterine life. Is their first respiratory effort. Excuse me, you're assessing respiratory effort. You always want to assess the respiratory rate while the newborn is quiet. So you almost always do respiratory rate as the very first assessment in vital signs. Your normal newborn respiratory rate is between 30 and 60 breaths per minute. It's very irregular. They kind of, they have a lot of pauses in their breathing. They will kind of that's very normal. Infants are abdominal breathers, so their bellies are moving quite a bit. You want to monitor for any substernal retractions, which you'll see very clearly if they're retracting. And for infants especially, you want to monitor the respiratory rate. You're going to count it for a full minute. Why do we have to count that for a full minute? Based on what I've already told you. Okay, so hopefully you understand that the reason is because the respiratory rate is very irregular. So just like we did heart rates for adults, if their heart rate was very irregular, you were going to count the apical pulse for a minute. Infants always have an irregular respiratory rate, so you need to count it for a minute. This is an apnea monitor. It detects respiratory movements, an alarm sound if no respiratory movement is taken within a predetermined amount of time. It's usually around 15 seconds. It can be used in a home setting, but it's often not done or recommended unless the baby has had what we call A's and B's, apneic and bradycardic episodes in the hospital. So if they have had some apnea and bradycardia in the hospital, they may go home on an apnea monitor. They have over-the-counter, or I hate to say over-the-counter, but apnea monitors that you can just purchase because parents are very concerned and worried about SIDS. And those are just, they are not recommended, honestly, for use. The parents rely too much on them, really. All right, then we've got pulse oximetry here with respiratory rate still. It measures your oxygen saturation of the arterial hemoglobin. It's used on the finger of an older child and around the foot of the infant. So you record it with other vital signs. It can be left in place for continuous monitoring if needed. And if it is needed to be done on continuous monitoring, then you will change the site every 4 hours and check the site every 2 hours. So it may have to be done on one foot, then on the other foot, on a toe, on the hand, on a finger. Very difficult on a finger for an infant. You're going to check the alarm settings at the beginning of each shift. And this is super, super important because you have no idea what the nurse ahead of you's done. And more often than not, the alarm may have been going off and the nurse felt like the baby was fine And so they altered their settings so where it would not alarm unless the oxygen saturation dropped below 80%, say. And that's really too low. So very first thing you need to do is check all of your alarms at the beginning of your shift. And that's not just for infants. In fact, that just happened back in January when my father was in the hospital. And I couldn't believe that the alarm wasn't sounding. And they said, oh, they must have reset the variables. And yeah, they did. And they needed to reset them again. All right, so here's examples of pulse oximetry. So here's for a child, and here's for the infant. There's a little light here, and there's one down here, and they need to match up. So the lights have to be going through the infant's foot, basically. And here's another one on the finger. It's like a Band-Aid, kind of like a stretchy Band-Aid. All right, pulse and heart rate here. Heart rate is, a normal heart rate is 110 to 160. For an infant, you count your apical pulse for the infant. Your radial pulse, you count 30 seconds times 2 in the older child. So you're going to assess the quality, the rate, and the rhythm. If they're on cardiac monitor, you're going to check the electrodes every 2 hours for redness and irritation, as well as making sure that the leads are secure on the child. Note any abnormal rates, any abnormal sounds like murmurs. Infants very commonly have murmurs because they have different, once they are born, their heart has to do a lot of transitions to extrauterine life. And so they will very often have just what we will call like a flow murmur that will close and stop having that murmur within a few days of life. But regardless of whether it stops or not, it still needs to be documented. All right, temperature. You're going to do an axillary temperature. Normal is 97.1 to 99.8. Can be done oral, rectal, axillary, tympanic, or temporal for your older child. Oral is going to be for children older than 4 to 6 who are conscious and cooperative. Rectal temps are for infants and young children less than 4 to 6 years of age, and per the book, it's not recommended for newborns related to the risk of perforation. Now, we used to do a rectal temperature on every baby as soon as they were born to make sure that their anus was patent, but they are actually not even recommending that anymore. Axillary temps, you have to make sure that there's skin-to-skin contact. There's no clothing in the way, so while it seems simple, sometimes that's a task in and of itself. All right, so here's your picture for your axillary temperature. And oftentimes, this one has the thermometer hanging out. I often can't get a really accurate reading unless I do an axillary temperature, the same way down here. Unless I do an axillary temperature with the thermometer this way. So all the way under the infant's skin. Okay. All right, blood pressures. It's part of a routine screening if you're greater than 3 years of age. You need to explain to the child what's going on. Just tell them that the little machine is going to give their arm a hug and that they need to keep their arm still because every time they move their arm, the machine has to hug again. And make sure that you use the appropriate size cuff, that it's wide enough to cover 2/3 of the upper arm. And they make itsy bitsy, teeny weeny, super small blood pressure cuffs. So make sure that you have the appropriate size cuff. All right. Physical measurement. So your normal weight, 5 pounds 8 ounces to 8 pounds and 13 ounces. It is very normal to lose weight. Now, how much weight should the infant lose right after birth, and why are they losing weight? All right. It's normal to lose approximately less than 10% of their birth weight. If they lose more than 10% of their birth weight, we start getting concerned. So as long as they lose less than 10% of their birth weight, that's very normal. And part of it is because they're losing fluids now. They're not eating as well in those first few days of life. Now, the birth weight will double by 5 to 6 months of age and will triple by the time they're 1 year old. Okay? So let's say our 8-pound baby at 5 to 6 months of age should weigh, 16 pounds, and by 1 year should weigh 24 pounds. Approximately. Okay, so whatever they lose initially, this initial weight loss, which should be, like I said, less than 10% of their birth weight, they usually will regain that within 7 to 10 days. That's when they really start picking up on how to eat. If they're breastfeeding in particular, that's when the mom's milk comes in and they start really being satisfied and eating better. Now, the baby will gain approximately 2 pounds per month until they're 6 months old. The average length is 20 inches. You do a crown to heel measurement. Crown is back here at the top of your head to your heel. You do head and chest circumference. So head circumference is occipital prominence around, I'm going to show you a picture, around to just above the eyebrows. Your average is 13 to 14 inches. And chest circumference, you do under the scapula posteriorly over the nipple line. Whoops. And it's usually no less than 2 centimeters difference from the head circumference. So here's your chest circumference right across the nipple line. And here's your head circumference. All right. Moving on, this head to toe assessment. So skin. Skin is a little bit reddish at birth and then turns pink within hours. You'll have some vernix, which is a white cheesy substance. It protects the skin in utero. Lanugo, which is a fine downy hair that I'm going to show you some pictures. Milia is these little tiny white papules, look like little pimples. Do not pop them. Acrocyanosis, birthmarks and skin tags. That was the information we showed earlier. Harlequin sign. This is where when the infant cries and gets really upset, literally you can see right straight through the midline, one side of the body turns red and the other side turns very pale. Jaundice, a yellowing of the skin, bruising over the presenting body part, forceps marks, sometimes a nick or cut from the C-section. All these things have to be documented. Okay, bruising in locations other than knees, shins, lower arms, like we talked about before, bony prominences, need to be looked at a little bit further. Any bruising other than these particular bony prominences, were really concerned with abuse. Okay. Here's your normal newborn findings. So hopefully you can see here some acrocyanosis. These hands are blue, very normal. This right here is the lanugo. This is milia, these little tiny white little dots. This is vernix, real cheesy like substance. Really hard to get off during the bath. You really have to soap and water that really good. All right. So with the head again, we're doing molding, which is when the overlapping of the cranial bones to fit through the birth canal. Caput is a swelling of the soft tissue over the presenting part. Cephalohematoma is swelling from bleeding. Cephalohematoma does not cross suture lines, and a caput does cross suture lines. Be sure that you understand the definition for all of these and what makes them different. If you have questions, please let me know, but make sure you understand all of these things. Sutures are where two cranial bones meet. You don't want them to be fused. They should be mobile for infants. That's why you have fontanelles. So they should be full. Fontanelles are like soft spots, what they call the soft spot. Have one up here and one in the back of the head. They should be full but not bulging. If they're bulging and really popping out there, we're really concerned with increased intracranial pressure. And if they're sunken in, we're concerned with dehydration. Okay, so again, be sure that you understand each one of these terms. If you have questions, look it up, email me, talk to me, let me know. All right, here's your picture. Here's your cephalohematoma. Remember, cephalohematoma does not cross suture lines. You can see how it's very specifically on one side of the head. And here's caput. Okay, this one does cross suture lines, and you can see how it's just the whole top of the head. All right, here's your anterior fontanelle, your posterior fontanelle, your sutures. These are your sutures. Sometimes they literally feel like ridges when you feel the baby's scalp, where they've crossed so much to get through the birth canal. All right, this is assessing range of motion of the neck. You obviously don't do this very hard. It's not forceful. You're just literally moving the head around, and it will turn very easily. All right, the eyes. Let's see a good place to put my picture here. Color for eyes is always blue-gray for fair-skinned parents and darker for darker-skinned parents, but it's not going to become the permanent color until they're 6 to 12 months old. I love it when parents say, oh, look, the baby has blue eyes just like me. Well, it may not stay that way. Sclera is the white of the eye, so it's white and clear. Pupils are equally round and reactive to light, just like ours are. Red reflex is present. They have uncoordinated eye movement, so they have what's called doll's eye movement. So if you turn this way, their eyes float up. If you turn their head this way, their eyes float up, just like those baby dolls did. They have tearless crying often because their lacrimal ducts are underdeveloped. They should have symmetry of the eyes, and you observe for any redness or drainage. And visual stimulation is very important in newborn care and development. Sometimes we kind of get used to doing the same things over and over again, and we'll put the baby to bed the same way, so with the head at the same side of the crib each time. Well, at that side of the crib, we have a little, some kind of toy that they're watching or looking at, so they're constantly turning their head that way to look at the toy, and they can get some restricted movement of the neck by doing that. And so oftentimes the pediatricians will tell the parents to put the baby to bed on the other side of the bed, move the toy to the different areas so that the infant has to turn his head different ways to see the toy. All right, nose. It is flat. Babies are obligatory nose breathers, so you need to make sure that there's no nasal obstruction. Sneezing clears out nasal obstructions. Nasal flaring is abnormal, so when their little nostrils are flaring out, that means they're having difficulty breathing. Babies can smell very well. You need to observe for any kind of symmetry, swelling, drainage, or bleeding. Okay. The mouth is moist and pink. You need to evaluate the suck and gag reflexes and check for an intact palate. So usually you just kind of put your finger, a gloved finger, in the baby's mouth. You go all the way back to the soft palate, and they will often gag. So now I've checked the soft palate. I've checked gag reflex. I come back to the hard palate. I've checked the hard palate to make sure it's intact. And then I will just kind of keep my finger there and try to get them to suck. And now I've checked their sucking reflex. Want to watch for any, or identify any Epstein pearls if there are any. They're little small white cysts, and I'm going to show you a picture. Or precocious teeth. Babies are sometimes born with 1 or 2 teeth. You need to do a dental consult if that occurs, and dentistry will decide what they want to do, but oftentimes they will pull the tooth in fear of the baby swallowing the tooth. You need to look for thrush, which is little white patches in the mouth. I get that call quite often when I was triaging phone calls. And one of the first things we always recommended is to take a baby's wash rag and wrap it around your finger and wipe the baby's tongue and see if the white stuff comes off, because oftentimes it's just milk that's stuck in their mouth. But if you take the washcloth and wipe the tongue and that white stuff doesn't come off, then it's thrush. Note any difficulty with swallowing. And if it's an older child, have them move their tongue from side to side. All right, so how are we going to assess for cyanosis in a child? Hopefully you will recall from the earlier slide that we discussed, in order to assess for cyanosis and oxygen saturation, oxygen status, is checking the lips and oral mucosa, right? All right. So here's the mouth. These are Epstein pearls. Okay, these got some little baby precocious teeth here. And this is thrush. You can see that white coating on the baby's tongue. All right, ears. Their pinna, the top of the ear, is very flexible with very quick recoil, so the ear pops back up quickly. The top of the pinna is even with or above the outer canthus of the eye. Okay, so here's your pictures down here. Even with or above the outer canthus of the eye. This is an abnormally angled ear. And this is your low-seated ear. So low-set ears will sometimes indicate congenital defects, such as Down syndrome. A hearing screen is done before leaving the hospital. If the baby does not pass that hearing screen, they will set up a second hearing screen very quickly after discharge and get things started. That they've shown significant improvements if the infant starts speech therapy and evaluation for hearing deficits. The earlier the better, right? Note any kind of drainage or swelling from the ears, any preauricular tags. So preauricular tags, they may have a little skin tag literally right here in front of the little thing on your ear, right here, like a little skin tag. Now the ears and the kidneys develop at the same time. So if you have preauricular skin tags, you have to be very careful about monitoring for renal disorders. Okay. So nowhere in here you notice we said there shouldn't be any lesions, scratches, bruising, or anything on the ears when you assess a child. You know, if there are, we may need to again consider some possible abuse issues. Okay, because it's very difficult to fall and hurt your ear. Okay. All right, abnormal facial features in children. So a low nasal bridge, having a very small head, epicanthial fold. See this little fold right here? Short nose, a smooth philtrum, so they don't have that little divot right there. Underdeveloped jaw, the real thin lip. These are all abnormal facial features and can indicate some type of abnormality. All right, the neck. It is normal for the neck to be very short and thick. The head should move very freely, but it's very significant head lag, like you see right here. He's pulling up and the baby's head is falling back. This is very normal. They don't have this muscle strength in their neck to hold their head up. That's one of the reasons why they tell you all the time, watch the baby's neck, watch the baby's head. Okay. Now the chest for infants is very barrel shaped. The xiphoid process is very prominent. And the infant chest moves with the abdomen with breathing. Oops, sorry. The infant may actually have little thin milk secretions from the breast right after delivery, and this is called witch's milk. And it develops because of the mom's hormones. Note any kind of breast development in older school-aged girls and adolescents. And report any respiratory complications. So what kinds of things might I see for respiratory complications? Well, we already talked about that we may see some substernal retractions. We may hear grunting, where they literally are just with every breath. And I've heard many parents say, oh, listen, the baby's singing. Yeah, he's not really singing, he's grunting. Okay, we may hear stridor, which is a high-pitched sound on inspiration. So we're like a okay. All right, here's a picture showing you some retractions. Intercostal, substernal, and subcostal retractions. Now, abdomen and GU. So the abdomen is obviously very dome-shaped as well for the infant. The abdomen moves with the respirations for infants. Bowel sounds can be heard within 2 hours after birth, and that is part of our routine assessment 3 times a day. We're checking for bowel sounds. The abdomen should be very soft without any masses. We're assessing the umbilical cord for any signs and symptoms of infection. So we're looking for yellow or green drainage oozing from the umbilical cord or any active bleeding. We're assessing for a possible umbilical or inguinal canal hernia, which I'm going to show you some pictures. For GU, you need to be sure and refer back to the lecture we did on GU last time for the last test. And checking skin turgor. Now remember, for toddlers and infants, we're checking skin turgor on the abdomen, okay, which is really different. And here's a picture of some abdominal hernias. This is an umbilical hernia, basically where the muscles just have not closed, are not closed all the way around the umbilicus here. And this one is an inguinal hernia. And same thing, it's just that the muscles are not closed up there. Sometimes they need to be surgically repaired. Other times they just kind of let it go unless there's a complication. All right, now we've got extremities. So flexion, flexed up is the normal posture. Good muscle tone with full range of motion. Syndactyly or polydactyly, which is the fusing or webbing of fingers or toes. It's not normal, but something we definitely have to monitor for. Happens more often. Actually, Oh, well, it does happen. Well, syndactyly is if using or rubbing of fingers or toes. Polydactyly is actually having extra digits. And that I see more often than I do syndactyly. We often have to x-ray little pinkies, extra pinkies or extra thumbs quite frequently, and they will x-ray them to see if there's any bone in them, and then they will make the decision as to whether or not they want to keep the extra digit. If there's no bone in it, oftentimes they can just take some suture and tie it off, and it will fall off without any complications. We need to assess for a simian crease, which is the single crease across the palm of the hand. It's indicative of Down syndrome. Brachial pulses, make sure brachial pulses are present and equal. The legs should be bowed and the feet are flat. They should have multiple creases across the bottom of the feet. Oops. Femoral pulses need to be present and equal. And evaluating the hips for dislocation or subluxation. Now the doctor actually does this procedure. And this is what he does. Well, he does these maneuvers up here, Ortolani's and Barlow's procedures. But what you would notice are things like this when you were doing your assessment. Notice uneven extra folds here. So we've got this extra fold. I don't have the other picture. When you're on their backs or on their belly and you can see their buttocks, same thing, you'll have uneven gluteal folds. Okay. They do sometimes what's called a Pavlik harness. And sometimes they do double diapering where they just put 2 diapers on to keep the legs spread apart. And what they're trying to do is let the muscles form and strengthen around the ball and socket to keep it together. All right, back and rectum. So the spine should be straight and flat. There should be no lumbar or sacral curves noted. No masses, openings, dimples, or tufts of hair at the sacrum. This could be indicative of spina bifida. We need to make sure that the anus is patent. Very first stools an infant has are called meconium. They're black, tarry, and very sticky. Difficult to clean up. Until they start getting some milk in them, formula or breast milk, that's what they've got. You're inspecting for lesions, sores, swelling, or discharge. Symmetry of the back for the older child, checking for scoliosis. Note their gait and posture in a walking child. Okay, here's a picture of a sacral dimple with a tuft of hair. It's a little bit difficult to see, but notice this is not completely closed and they have this tuft of hair right around here. That would get ultrasounded to determine if there were any kind of nerve damage going on, such as with spina bifida. Here's scoliosis, so we've got uneven shoulders, the curvature in the spine, and uneven hips. Right, during the neurological assessment, general appearance and behavior, the first part you want to do is a very general, quiet observation of the newborn. So they should maintain in the flexed position. Hypotonus would be very flaccid. Their arms and legs would be straight, flat out. Or hypertonus would be jittery, so they'd be just like this, shaking all the time. And these are both abnormal findings. The cry should be vigorous and medium pitched. A very high pitched cry is not normal, and you will know the difference. Then we have these different reflexes. Again, I need to triple check on these page numbers, but we've got rooting, sucking, swallowing reflex, the plantar and palmar grasp, stepping reflex, Babinski's, Morrow, tonic neck. Okay. Here's rooting. That's if you do this on the baby's cheek, they turn their head over to try to suck. Here's your palmar grasp and your plantar reflex, where they pinch. If you put something in the palm of their hand, they squeeze. If you put your finger on their toes, they curl their toes in. Babinski's, this is the foot. You'd run across like, you would run across like this on their foot and their toes fan out. That's Babinski's. Oh, here's a picture of Babinski. This is your tonic neck reflex. This is the Morrow or the startle. And this is the stepping reflex or dancing reflex. If you put their feet flat on the ground, you hold them up, put their feet on the ground, their feet will come up and down. Oh, let's see here. Gotta figure out where I'm at. Here we are. Performing the neuro exam after head injury, seizure, metabolic conditions, hemorrhage, and dehydration. Glasgow Coma Scale, just like you would for adults, neuro assessed every 1 to 2 hours after an injury, and the neuro assessment is the most complex part of the physical exam. All right. Behavioral assessment, monitoring bonding with the infant and parents. Note how the parents react to the infant behavior. Can they care for this baby? Are you comfortable sending this baby home with his mom and dad? Are they going to take care of it? Are they going to react when the baby cries? Are they going to pick it up? Are they going to make sure it gets fed? Notice the active alert states. Are they playing with the baby? Drowsy? Let the newborn rest. If the newborn's crying, it has a need. I get multiple calls. Why is the baby crying? I don't know why the baby's crying. You have to check things out. So you'll want to check and see. Is the baby wet? Does the baby have a dirty diaper? Is the baby hungry? Is something bothering the baby? One thing, story that I've heard multiple times actually, where a baby was just crying, screaming unconsolably. The parents could not figure out what was going on. They finally undressed the baby, and sure enough, what happened was a hair had gotten wrapped around the baby's toe and was cutting off the circulation to the toes. So check all the physical problems first, then try soothing actions, reassuring the parents that they won't spoil the child by picking him up all the time. Right, in the hospital, in the pediatric unit, it's a warm, friendly atmosphere. Children are encouraged to wear their own clothes during the day, and comfortable gowns are available to wear if they don't have their clothes or they can't wear their own clothes. Staff members also wear colorful clothing. This is one thing at the university. We all went to a dress code except NICU and Peds, and they are to wear colorful outfits so that it's being more friendly for the kids. Another different thing is that treatments are done in a treatment room. So in the hospital setting, if there's going to be things like an IV stick or a catheter, they don't do these procedures in the child's room because they don't want the child to be scared and terrified. So what they do is take the child to a treatment room to do procedures, and they decorate it real fun. But that's where the procedures are done, and then they bring the child back to their room. And they have play areas. They allow the parents to stay in the room and involve the caregiver as much as possible. Okay, that's it.